Okay, so I believe it's recording, so we at least have that happening so we can share that with Mike and Katie. I think so. Okay, it's happening. Great. So Emily, oops. Thanks. Why don't you go stand there so I can try to get this on you as much as possible. Get the microphone this side. There we go. So if they want to see you in the corner presenting what you're doing, you can. Yeah. The world of hybrid meetings, so many additional logistics. Hey, folks. All familiar faces, of course. Good morning, everybody. Or it's not morning anymore. Good afternoon, everyone. I'm Dr. Horan. I think I know most of you. I am not the one who's responsible for running Fable, but Mike Fetterhoff is out of town for a conference, and Katie is also, Dr. Chu is also not here today. So I'm stepping in just to introduce Emily, and I'll hang out here in the audience with all of you. And we'll get started in just another minute. I think we'll let some additional folks trickle in. You do have very good posture. Emily's just admiring your posture.
Yeah, it's kind of like perfect.
My posture starts off really strong at the beginning of the day, and then at the end of the day, it's sort of I stop having such good posture. Okay, so it's 12:02. We're going to go ahead and get started. Thank you everyone again for coming to Fable today. I'm going to read a brief bio about Emily, though Emily and I work together, so I could talk at length about what she's done and what she's achieved. But to be brief, I will just read this brief bio, and then I will pass the torch to Emily to get started. So Emily is a second-year master's student pursuing a dual degree in biocultural medical anthropology and public health. Her research interests include lactation support, collaborative care, syndemic theory, and reproductive health. Emily's thesis explores how the combined effects of multiple disasters impact perceptions of infant health and well-being in Alabama's Gulf Coast. During summer 2021, Emily established partnerships with multiple community organizations and groups in Southern Alabama, including the Gulf Coast Doula Collective, Butterflies Dancing Perinatal Support, and the Mobile County Health Department. She is now training to become a postpartum doula so that she can provide services to moms and birth givers in Alabama. Take it away, Emily.
Yay! Well, first, everybody, thank you for coming. I appreciate it. If you're here with the 100 class, you can sign up over here and get 5 points extra credit. That's great. That's an easy way to do well in class. So yeah, like Holly said, I'm a second-year master's student in biocultural medical anthropology and public health. And I'm also an emerging community engaged scholar. So basically, this is a program through the Center for Community-Based Partnerships here at UA, where we sort of get together. There's a whole range of professionals and professors and students, you know, from like, I think graduate up, talking about their experiences working with communities, but also talking about the challenges and sort of like, we're all there to learn together, because I am certainly not an expert here. I think I'm just sort of new to this and I'm starting out. And so I'm here to share what I've learned so far in that program and from just my personal experience. So. Okay. Oh, and another thing too is like, one of the reasons I was interested in community engaged work is because I wanted to have some impact, like a positive impact on the communities where it's most likely to affect them. And I want it to sort of facilitate long-lasting, long-term partnerships. So my thesis project is grounded in critical medical anthropology. I'm using the theory of syndemics and sort of to explore the ways in which multiple disasters, and so multiple disasters are like the compounding effects of tornadoes and hurricanes and flooding and COVID-19 and everything else that hits Alabama all at once, and how those experiences have shaped perceptions of infant health and well-being from both the provider perspective and the birth parent perspective, or birth giver. And Then I'm looking at like, okay, so this is how these events impact their perceptions of health. How does that then impact into feeding decisions, or does it at all? So that's what I was working on summer 2021 this summer. And I interviewed, I took a mixed methods approach. So it was 10 providers and 10 birth parents for the interview, so the qualitative portion. And then I had a quantitative survey for the entire Gulf Coast of Alabama. And that's intended to sort of inform my future dissertation work and get a broader understanding of the area as a whole, whereas the interviews were conducted mainly in Alabama's Gulf Coast. So right now I'm in the preliminary coding stage for my interviews, and there's just a lot. I'm like learning throughout the whole process, but I was able to collect some of the demographic information. So I have to like flip my page on that thing. The median age was 42.5 or 42 and a half for providers and professionals, and the range was 29 to 61. So they're on the little bit of an older side. The race, so 8 people identified as white, 1 person identified as Black, and then another person I asked, I said, you know, how do you racially or ethnically identify? And they're like, American. And I was like, okay. So, so American and other, and this is actually starting to crop up in the quantitative results too. So it's something that I might want to explore further if it is a common theme in the area. But yeah, and then there's a range of professions that I was able to work with and also talk to. So CPM is a certified professional midwife, and she's also a doula. I accidentally ended up volunteering at a pregnancy crisis center. Does everybody have an understanding of what that is? Okay, so it's an anti-abortion center primarily. So how I got there is a really long story, so we won't get there. But anyway, so I started just showing up to their educational classes, and then I was able to interview their director, which was super fascinating. And then I spoke to a few nurses, lactation consultants, one pediatrician. It was really difficult for me to access the obstetricians, although they are really integral to the process of infant feeding and health, a sonographer, and a WIC coordinator. So it's a range of professions. It was really interesting talking to everybody. And it's actually, so the most recent data for professionals is from 2013, and about 6.6% of physicians, regardless of their specialization, are Black in the state of Alabama as of 2013. So if we sort of assume that that's remained static, or the numbers have only gone up a little bit due to structural barriers to medical school, this is somewhat representative, unfortunately, of that. Although there obviously is an overrepresentation of white people. For birth parents, the median age was 29, so we're on the younger side, and the range was between 22 and 37 years old. So there's a range there, but primarily younger. And then I was able to interview 7 white moms and 3 Black moms. And so in Mobile County, it's 59% white, 36.2% Black as of recent census data. And then Baldwin County, because I was looking at both, is 87.4% white and 8.8% Black. So it's somewhat representative of, with such a small sample size. But yeah, so that's how that turned out. And then, so these are the demographics from my quantitative data from the survey. So my goal was 30 per provider and birth parents. I actually got 79 responses for the birth parents, but I haven't submitted the IRB amendment yet. So I'm going to report on the first 30 and then 27 for the providers. So that if you look, the age ranges were similar. Obviously predominantly white. I mean, 28% white birth parents, or not 28%, just 28 in general white birth parents out of 30, and then 19 white providers and professionals, which isn't really surprising for the area. But again, this is for the larger Gulf Coast. So it includes Alabama, Florida, Louisiana, Mississippi, and Texas. And then Hispanic, there were 4 Hispanic or people who identified as Hispanic, and then 4 people identified as other, and most of them were American, which is so interesting to me. And so Florida was like popping. They were like, give me this survey, I'm gonna answer, we have things to say. So that was great. 5 for Louisiana, 2 for Mississippi, 4 for Texas, and 1 for other. I probably shouldn't have put that on there as an option, that's okay. And then 18 people identified as male and 9 identified as female, which is really interesting. But also obstetrics and the birth world in terms of like the allopathic setting is primarily male dominated, so it makes sense. And then over here, the first 30 were from Alabama, which makes sense because that sort of follows with my recruitment efforts. It was all like in Alabama. And then all of them identified as female. Okay. So none of this would really be possible without the help of my community members. This is, what was so important to me, and they made this happen. Like I would not have had access to any of these providers or birth parents without them. And so for the purposes of this presentation, I'm going to use the word community engaged as like an umbrella term for a much larger continuum of like community engaged work and community engaged scholarship, right? So there's different levels of community involvement with your research or your involvement with the community, however you want to look at it. And so we'll get more into that in a second, but right now, just sort of overview of what community engaged scholarship is. It's rooted in sort of involving those who are most likely to be impacted by an issue that you're researching in the research process itself. So a lot of times researchers will, particularly healthcare researchers, will identify a problem, especially with like, social determinants of health, right? They're interested in mitigating the effects of inequity. And they will create these interventions, but they may not consult with the people who will actually be, receiving the intervention. Or supposedly benefiting from it, and oftentimes they don't work necessarily. So this is one way. I know the CDC published a thing on community-based participatory research, which is like the golden standard of community engaged work, to sort of like mitigate that problem. So that's like the overall principle of it. And the goal is to build trust, which I think is really important in the COVID-19 world, right? With vaccines and everything, especially in this space. So building trust with the community outside of the ivory tower, enlisting new resources, and then of course creating better communication and long-lasting partnerships. And so it's all about this like mutually beneficial collaboration. So it's not just the researcher going in and asking questions and taking information and leaving and never seeing them again. It's like let's sit down, let's try to level the playing field. There's always going to be a power dynamic, but try to level it so all people there are contributing in some way. Okay, I love this. I printed it out and put it on my corkboard. So this is a graph. It's the structural framework for relationships. And okay, so it's really complicated. Normally in community engaged work, we think about like the academy and the community. It's like big C, like big, like the community, like what is a community, right? Well, so there's big C, which is like everyone outside of academia, and there's like little C's, which are like all like the nonprofit organizations and the actual community members. And then academia, like the academy, is not just me. It's my advisor. It's like the whole department. It's arts and sciences college. It's my funders, and it's the IRB. So I like this because there's 10 dyadic relationships that overlap with one another. So you've got like the administrators and the community organizations, community residents, and community for me is also very complex because you have like hospital administrators and public health officials, and then doulas and midwives who are sort of on the like outskirts of the medical system. And then you have birth parents who may also be doulas, and they're all interacting with you. And some of my participants are on my IRB. And so this is a way to sort of put it all together and say like, okay, this is really how complex this work is. Okay, so this is the continuum of community engaged like work that I was talking about. So community engaged is like that umbrella term, and this is everything that you can do within that, right? And so it's sort of like a step-by-step process in a way, because it's all about the different levels of engagement. So you have community informed, And community informed is just, it's sort of defined as like, you go in, it's our participant observation, basically. So you are in with the community, you're living there, you're volunteering at a nonprofit, I literally, okay, I volunteered at birth classes, and I was like up in front of a whole group of people, like pretending to give birth. But it was really interesting. But that is community informed. They're not directly participating in my research, but I'm taking what I learned in writing it down in my field notes and then using that to inform my research. Okay. And then you've got community consultation. That's actually going to the community and saying, hey, I have this project, what do you think? Taking that feedback. And then it just gets more involved from there. And like I said, community-based participatory research, it's like that golden standard. That's when the community is really like running the show. But it takes a lot to get there, and long-lasting partnerships and a lot of work and commitment. So yeah, there's also these equity indicators. So there's always going to be a power dynamic. There's always going to be concerns over who has control of the data, responsibility, who is making the decision, and they vary at different levels. And then you have to consider the contextual factors, where you're conducting the research, level of transparency, respect, all of that stuff. It's very complex. Okay, so this is where I'm at. So community informed, again, that was my participant observation. I also attended a lot of vaccination clinics, which is really interesting. What else did I do? Oh my God, I babysat a lot of kids. Yeah, but it was fun. I never got to attend a birth, but I almost did. I was invited to a couple births, and I attended the like Gulf Coast Doula Collective, where like midwives and doulas would get together, and they would show me how like your pelvis moves, which is awesome, during birth. And then community consultation. So Holly and I sort of like designed our project, and then we went to our key informants who were involved in another project. That's how we knew them. And we asked, we're like, this is what we're interested in doing. Do you think this is something that you're interested in? Because really, like at the core of community engagement is like, I want to do this work because I don't want to do something that people aren't interested in. So, and they provided feedback, and they were like, yeah, I think this is great, or you should add this. And so that's community consultation. And then community participation, I have a perinatal health specialist. She's on my IRB. She's also a child therapist. She's actually working on analyzing the data right now. So she's very involved. Oh, and the Mobile County Health Department, they would schedule all these like vaccination clinics at these women health clinics. And they're like, you gotta go like do this. And like they would like basically create my schedule based on what they thought would help my research, which was really cool. But then sometimes they were so involved, it became a little bit of a problem. Like one of the nurses I work with, she said she found someone at Walmart. She's like, this lady looked like she needed help. So I told them about your research. And I was like, oh, what do I do? Like, I really didn't know. Like, that's so like wildly inappropriate, but also like, I appreciate your recruitment efforts. Thank you so much. But maybe let's, yeah, so it gets complicated pretty quick. Okay, so for me, this is really important. This is how I found community engagement to be most effective. This sort of addressing the power dynamics, recognizing that they're there. You're not going to really be able to get rid of them, but you can mitigate the effects. And also like really like thinking about your position and how it contributes to this idea of authoritative knowledge, which is defined as a system that gains dominance over all others. So basically some domains of thought they hold more weight than others. So it's kind of relates to like Marvin Harris's, we learned about the emic and edic. And it's kind of like how the edic perspective, he was like, oh, okay, we're talking to the community partners, but like at the end of the day, like edic is like this is what's really going on. This is both sides. So it's kind of like that in a sense. And again, a lot of researchers, including like, I mean, I'm sure I've done it in other contexts of my life, but going into communities and saying like, this is what I know, and I studied lactation, and I'm here to tell you about it. And that's a unidirectional flow of expertise. And we really want a bi-directional flow of expertise. So really treating this as like, these guys are the experts. I'm just here to learn. Okay, so this was another exercise I did. This is the doula collective, which is a lot of fun. There's like midwives and doulas sitting around, teaching me all about birth, which they didn't have to do. I really appreciated it. But before I went into the field, I had to really think about how my identity and my position would impact not only how participants interacted with me, but how I interacted with participants, and how that would sort of inform my data and my research and who would recruit and who would talk to me. So there's positionality is really like the social and political and economic context that you grow up in and how you, like what has formed your identity basically. So there's all of these different aspects, but then you can map it out. So this is a recent publication by Jacobson and Mustafa from 2019. They created this like social identity mapping, which is a positionality exercise. And so I did it, which was really fun. And I obviously modified it for things that I felt were most important to my research and what would impact my ability to work in the field. And then, so these big ones are like what affords you privilege or oppression, and then everything in between. And then I'm able to nuance it a little bit with this, which I really like because, for example, I'm middle class, but middle class is really, really broad. And growing up, I was on paper middle class, but there was a lot of financial instability. I had to work this job. I worked as a housekeeper when I was 16. I had to clean 30 toilets a day. Like that was gross for 6 months, you know? And so those types of experiences, I mean, that helps me interact with some participants. Like one of my participants was a trucker. And she was like, I hate working. And I was like, girl, same. Like, you know, I to a certain degree, like I've kind of been there. So it helps you relate versus if someone had never had that experience, they might be like, you're lucky you have a job, you know, all those like stereotypes about working and stuff like that. Physical mobility, I really took advantage. I took for granted what it was like to be able to walk around freely. So that's a big one, especially in Alabama where transportation accessibility is not entirely available. And then I also have some mental health issues that actually I felt like allowed me to connect more with postpartum parents. Like I would be like in an interview and they would be like, you know, kind of hesitant, like they want to talk about their postpartum mood disorder, but they're like, you can tell just like based off of how they're talking and what they're saying, that they're kind of embarrassed. And I'd be like, yo, depression sucks. And then they'd be like, oh yes. And it was just like a flood of information. So that was actually helped me out. Age, of course, and then being white, I have immense privilege as a white person. Institutional ease. I don't experience racial profiling or microaggressions, and that's really in every single space. So that is huge. And then another thing that came into play was where I was from, which I didn't anticipate. So I have like the privilege of being Midwestern, or what's the unmarked accent, but okay, sometimes I sound like a hillbilly a little bit. Like it's very like Southern Ohio, you know? So when I talk really fast, it's like I slur everything together, and a lot of my participants made sure to let me know. Like, oh, I'm sorry. They're like, where are you from? Why do you talk like that? Yeah. And then also like Southern born folks are hesitant to engage with people from the North, given the history of like othering and really just that really complex history between the North and the South. So I mean, it's a valid hesitation. And then being a cisgender woman, I experienced institutionalized sexism within the academy, but also, I mean, at hospitals, with a lot of the providers that I spoke with. It was really interesting how some of them have just the internalized misogyny. That's unfortunate, but it grants me immense privilege in the birth world because the majority of birthers identify as cisgender women, and so are the doulas and midwives. Okay, so this is like the big one that I saved for last. So I struggled with this so hard. So I am extremely I am extremely uncomfortable with Christianity. And it's like a problem. When I was 9 years old, I found out Santa Claus wasn't real, and I was like, well, God can't be real, and then that was it. Like that was it. So, I mean, that's just my own personal view, and it really was very interesting. It was something that I didn't entirely prepare for when I was in the field. So, I know Malinowski talked about how it's important to have, you're like living with the natives, but then you also have like your own separate space. I did not have that separate space. She was lovely. I like loved her, but she would wake up every morning at 6 a.m. and read the Bible for 2 or 3 hours and then go to work and then come home and do her Bible studies and then go to bed at 8 p.m. And so given that I was actually like working with the pregnancy crisis center, sometimes it's just a lot. And I learned a lot. I was really immersed. And so a lot of the healthcare and education, especially in the South, is very faith-based. So the pregnancy crisis centers really serve as there's basically like this vacuum where there's not enough services postpartum. But the pregnancy crisis centers fill that gap. And so they're providing all the education. So they're incredibly important. I have to work with them, right? And I want to work with them. This is where all the women are going to get their postnatal care. But it also made me uncomfortable. We just prayed a lot. I learned how to do this thing, which is cool. And I would call Holly every single day and I'd be like, I literally can't do this. What's happening? And she's like, okay, it's okay. You can. So then once I sort of got more comfortable with it, I was like, here's a long list of family members. They're whack. Pray for them. So I got everybody on board and we were doing all that fun stuff. So my language, I had to work on the cursing. That's a huge thing. I didn't realize sort of down in some of the communities, being just not as fancy bad words. And I'm also not married. A lot of people thought I was pregnant because I'd carry my pregnancy books around. And then a lot of people were like, you're 24, you're really old. You should probably have a child. And I was like, oh, okay. Yeah. So that's just something that I really have to grapple with. And it obviously, I have this internalized bias. And so it's something that I have to focus on and think about how did that impact the way participants spoke with me. It's pretty obvious. They'd be like, oh, we're praying for you, or bless you, have a blessed day and stuff. And I'm sure my bug eyes, yeah, I got better at it. And so then a key part of this process for me is the democratization of data. So these are not my experiences, they're my participants. And I want it to be available. I think it should be available. It's not my information to own. And it's beneficial because it reduces power dynamics and sort of breaks down the colonial underpinnings of the academy. So, and science in general, especially thinking about the history of anthropology. So one way to do this is through member checking. And member checking is when you actually go back to your participants and you share the data and you check it. So you basically say, these are the themes we identified. This is the data found. What do you guys think about this? And you can have targeted questions. And we've been doing it with Holly's project. And it's awesome because sometimes they'll be like, no, this is wrong. This is not at all what's going on. And so we're like, oh, okay, cool. And then we'll write it down, we'll talk about it. And yeah, so we see how well it resonates. And then they also have the opportunity, but it is part of the data collection process. So you can't invite anyone else. These are closed events. And I'm hosting one in December. And we're going to see how it goes. I have no idea what's going to happen. It'll be so interesting though, because I have the people from the Pregnancy Crisis Center going, along with a lot of other people who feel very strongly the other way. And so trying to present that data is going to be really, really interesting. Yeah, it's going to be fun. And then the challenges and benefits. For me, I am so hyper. I have so much energy and I just want to do everything. And my timeline does not match a midwife's timeline. It just doesn't. They have a million births, same with doulas. And I might, especially even on a more broader scale, the academy expects you to publish. They want you to meet your outcomes. If you are grant funded, you have to make sure that your outcomes are met. You have to have measurable things, right? Yeah, so that can be a barrier to working with the community, which is why a lot of people don't do it. And then sustainability. So like my project for this summer, it's funded, and what I'm doing basically is I'm providing postpartum care with a midwife. And we're gonna evaluate, we have a tool that we're gonna evaluate the outcomes with. But what's gonna happen when that money fund like runs out? So I'm trying to work with other postpartum doulas in the area. They're very scarce. There's only one or two. To sort of create that sustainability model and so it can continue after I'm done. And it helps identify and resolve ethical pitfalls, makes it possible for communities to reap the benefits, and it elevates their voices at the institutional level. I love this photo because this kid is like clearly trying to crawl up on the cupboard. This girl was eating she had her whole like drumstick in her mouth, and I was like, oh no. Wow. So it represents the challenges of work. Okay, do you have any questions, or what questions do you have? Benny.
Is there a big difference between midwives and doulas, or is it like semantics?
No, there's a big difference. Okay, so midwives are actually trained to like catch the baby. Like they are there throughout labor the entire time. Like midwives are supposed to be the ones to attend birth. So obstetricians are actually just surgeons. They should only really ever attend the birth if there is an emergency cesarean. But that's not how our system is organized in the United States. That's how it's organized in Europe, but that's not here. Almost everyone sees an obstetrician and not a midwife. So midwives were actually illegal until 3 years ago here in Alabama. So they really are on, like when I say outskirts of the medical community, I mean, they're like, there's like a revolution. Like it's crazy how these midwives have to work. How there's so many structural barriers to limiting care. Whereas a doula is an emotional, we provide like emotional, informational, and physical support. So we're non-clinical, and we serve the patient, or we serve the birth parent. And so we're just there, like really they cropped up in the 1970s with the over medicalization of birth. Everything was moving into the hospital. Midwives were kicked out well before then, actually. And so it's sort of just there to help moms advocate, because when you're like laying down on a table or on the like hospital bed and you're about to give birth and you have all these people in white coats and glaring, white lights, it's difficult to advocate for yourself. That's the difference. Yes.
I was wondering if you could talk a little bit more about how you navigated and the power differentials and some examples of how that can be mitigated in your experience.
Yeah, so just like one way was I actually started, when I was at the Pregnancy Crisis Center, I started attending all of the educational classes, and I would just I became like the babysitter. Like literally moms would like walk in and be like, oh, take my child. Dear God, just take it. It's like, okay, so I have like all these babies. And so just sort of like being that supportive role was helpful. So like participant observation really, and just like really being there. I know there are some like with science and there's some ethical boundaries. I don't have boundaries. It's bad. None. Not a boundary. But that's sort of how I did that. And then when I was interviewing people, it became very clear when my language was too academic. So one girl, like she really didn't, you could tell like what I was just like talking way too academic. It was too scientific. And I asked her what her age was, and you could tell she was kind of just like really wary of this. She's like, I'm 23. And I was like, oh, girl, I'm 23 too. And then I was like, okay, time to like drop it down and talk to her. Like, let's like get on the level. Like, I'm not in class right now. That's what I did. Yeah. Benny. Benny.
Yeah,
I love it.
Okay, so when you're working with these really like religious populations in the Deep South, if you ever slipped up with things like cursing or stuff like that, if you did, I'm not sure, how were you able to like?
I slipped up so much. Oh my God. Well, I didn't know how to pray. Like, I didn't know how. So I was just like, everyone's like doing the thing. And I'm like, you know, is this what I'm supposed to do? Yeah, the F word was a real problem. I worked on it. I just worked on it. I mean, most people are understanding, like, I can apologize, be like, I make like a joke, like, oh, sorry, I'm from the north, we're like rude. I'm just sort of, which I don't know if that was appropriate, but that's what I did, and it helped like make it a lighter situation, and then it was okay. But in the extremely religious settings, I had to be very, very careful. And I like respected it, right? Like if they said we're gonna pray for you or bless you or whatever, like that's their way of saying like we really care about you. Like they would always check in on me and message me. They still check out on me right now. Like how are you doing? I think the real concern is how ethical it is. A lot of them, one of them wanted me to run their Facebook. Yes. And talk about how the vaccine's killing babies. And I was like, no. So like you do have, so I do have some boundaries. But thank God. And then another, so I was actually at a vaccination clinic at it was at a homeless shelter. Well, we don't have shelters. There's no shelters. There's like a couple, but they're very limited to who can access them. So it was a church, which sort of acts as like the proxy. And the founder of one of these women, they're called women resource centers or pregnancy crisis centers, was there. And it was this like white dude who was like an accountant his whole life. And he's very Catholic. Maybe he wasn't Catholic. There's like the Catholic ones, and then there's like the not Catholic ones. Like I think it's Baptist. But he was talking, he came up to me and he's like, so like I'm like helping people like get their vaccine. He's like, I've heard that you're here to save the babies. And I was like, I mean, you're not wrong. Kind of. You're kind of wrong. It was very interesting. And just the things he said about there's just a lot of ethical complications. Like the things he would say about these women, it was horrible. Yes.
Like with that, did you have a lot of problems with people like taking your research out of context like that?
I mean, so everything was pretty controlled with the interviews. So like I have a semi-structured interview guide. So like not my actual data, but in terms of like people understanding what I did.
Yeah.
I mean, there's a fine line. Like you really have to know how to answer. Like I had to answer. I said, oh yeah, I'm just interested in. I think that postpartum period is so important, and I think it's great that you're providing those services. There's clearly a gap in the state, so it's sort of just avoiding the question. And I mean, they do misinterpret it. They not they. I don't want to talk about it as it's like this homogenized thing, but some of the more religious spaces, and yeah. Yes.
With religion, like, how open were you able to be about that you're not religious?
I
Like,
never told anyone. I would not be comfortable doing that. I mean, I didn't say I was religious. I just didn't like, or I was like, I'm sending you love. Like I wouldn't say like I'm praying for you, but I'm sending you love. I'm worried about you. Yeah, a lot of the obstetricians are on the board of these pregnancy centers, which is also another, that's interesting. That's a bit of an ethical concern from my perspective. But again, you know, these people, like also talking to them, like they really, okay, some of them really think that like they are, like this is what they believe, like they're saving babies. Like this is something that they're passionate about. And so trying to understand like the, like to me, from the Eden perspective, like I think they're doing a lot of harm. A lot of my participants, they were in those classes because they were going to Planned Parenthood, and the education, the person who was teaching them was there. She was praying for them. She said, you know, you're at the wrong place. You need to go over here. You're not at, this isn't where abortions are provided.
Was she outside?
Yeah, they're positioned next to each other. So you need to go over here. So it's hard. So but at the same time, like they really think that they're saving. Why they prioritize an unborn fetus over a mother is, I don't know, it gets really complicated. Sorry. I don't know. Yes. Thanks.
Yeah, sorry, last one.
No, bring it. I love talking about it.
Obviously, you would do research during COVID, that's weird, and obviously, you're working with very religious and probably very fundamentalist people. I'm curious if you had any like insight into where you sort of draw the line as far as keeping yourself safe during a pandemic while also making the population you're working with feel as if you're respecting their beliefs too, as far as like some, I'm not sure if you would have encountered this, but I know some people around where I live are like very anti-mask and yet like offended if you wear one around them.
Yeah, so that's how the doula collective is. And most all of the midwives are anti-vax down there. But it makes sense if you contextualize that. So I mean, but like I said, they're on the outskirts of the medical field, and almost whenever they encounter a hospital birth, the doctors are abusing a patient, or I mean, it's just insane, or they're giving them unnecessary medication. They're not asking for consent. So all they see is this distrust, and so it makes sense. So for me, contextualizing it helped me in terms of staying safe. Well, it was during that like 1 month where we didn't have to wear masks. So I actually didn't wear a mask when I was with them, but I was vaccinated, so I personally felt comfortable, and I didn't live with anyone that would have been immunocompromised. Now it's gotten more complicated now that doulas in some of the hospitals are considered essential workers, but they have to be vaccinated. So the doulas aren't vaccinated, and they're like, hi, are there any doulas who are vaccinated in the area? And no one is. They're like, can you come down? I'm like, no, I can't. I've never been trained. I'm like, oh my God, no. I'm just gonna listen. I'm a white chick from Ohio. Don't. Like, I can't. But so it's complicated, and that really also speaks to just the lack of care. I mean, oh my gosh, there's only like 15 doulas or something. But yeah, keeping yourself safe. It was. I mean, I could wear a mask, and they would respect it because there's also the idea of medical freedom, which midwives and doulas are all about. So I just sort of harness that energy. Thanks for coming.